you very much to the organizers for inviting me. This is obviously a topic that we all face, and one that I became interested in going back many years to when I was a fellow and was taking care of patients where we were struggling really to provide the care that we as physicians thought they deserved, and were facing the political and social realities of the care that we wanted to give versus the care that we were able to give. So let me set the stage. At least this is going to be focused on U.S. policy. Undocumented immigrants with ESRD in the U.S. currently are ineligible for federal assistance from Medicare, Medicaid, and also from insurance that was initiated during the Patient Protection and Affordable Care Act, or the exchanges. Currently in the U.S., only select states have funding strategies that cover chronic ESRD care. And because of that, in the majority of states in the U.S., immigrants who are undocumented are forced to resort to emergency-only dialysis, and that's really dictated under the 1986 EMTALA Act, or the Emergency Medical Treatment and Labor Act. Now, what I was going to show you is that the key word there is emergency. And while we may all in this room decide what emergency is, when politicians and lawyers get together, the definition of emergency gets very complicated very quickly. Now, it's a very complex issue. It's an emotional issue. It's a political issue. It's one that tests the intersection of values, issues, politics. I would argue that at the core of it, it's fundamentally a humanitarian problem. But it intersects with people's value systems, obviously with very strong political views, also with professional ethics and financial realities that we all have. And I am sure in this room, having given this talk in other venues, is that reasonable people will have very widely different opinions and viewpoints on the problem and would offer very divergent solutions. It doesn't mean that anybody is right or wrong. It means that we want to respect each other's opinions, but fundamentally, it's a complex issue that has complex solutions. Now, in terms of an overview, what I want to do is show you some trends in demographics, talk about countries of origin, and then talk about estimates of the problem that we have facing us. Now, not surprisingly, what you saw up until about 2010 was that there was a continued rise in the number of U.S. unauthorized immigrants. That total rose to estimates that were a little bit above 12 million, and then not surprisingly, as politics intervened, a new administration with different values and political views, and immigration became much tougher and enforcement at the border became much tougher, what you see is that there's been a fall by nearly about 2 million in the population of undocumented immigrants. And this data comes from the Pew Charitable Trust, which I think is widely regarded as the best source for this information. Now, when you look, however, at the population, the current population of undocumented immigrants is growing older. They're living in the U.S. for a much longer period, so that when you look at this graph and look at the median years of residence, that number is climbing every year, and in 2014 was about 13.6, nearly 14 years of residence. So those who are undocumented and entering the United States are staying for longer periods of time. And when you look at the profile of this population, what you see is that in terms of all unauthorized, estimates of about 11 to 12 million people, the vast majority come from Latin America, Mexico, El Salvador, and Guatemala being the three most common. The population, again, is getting to be where the majority, 7 million, have residence greater than 10 years. And the age is equally distributed between about 50% less than age 35 and 50% greater than age 35. And then finally, about 15% have a bachelor's degree or higher. The employed population is about 70% of undocumented immigrants have documented employment. And access to health insurance is probably more closer to about 45 to 50%. This just shows you the top 10 countries of origin. Now, this is important because as we try to get estimates of the population that may be at risk for end-stage kidney disease, that certainly is dependent somewhat on patients' ethnic origins. And again, Latin America accounts for nearly about 60 to 65% of the population, with multiple other areas of the world also contributing smaller percentages to this issue. The top 10 states of residence in the U.S., not surprisingly, California, about 20%, and Texas, 15% are the ones that have the greatest population, followed by Florida, New York, states that are on the eastern coast of the United States, as well as Arizona, and then a small smattering throughout the US. Now, this is important as well when you look at the policy changes that are really dictated on a state level. Many states are have very sparse populations, not greatly affected. They don't really have policies around this population. Other states are finding this as an incredible challenge, like California, Texas, and there's been huge debates in those states as to what is the right course to follow. Now, interestingly enough, when you look at labor force participation in terms of undocumented immigrants, what you find is that estimates are that between 65 and 75% of the immigrant population is actually gainfully employed. They're doing some work, earning income. That's actually higher than the native population in the United States, which runs at about 70% or 65%, depending upon the study. Now, importantly, too, and this I think gets lost in the debate sometimes, is that actually many of those employed undocumented immigrants are actually contributing to Medicare and Social Security without reaping any benefits because they're ineligible for those benefit programs. In 2013, the estimates were that that was about $2.5 billion to Medicare. How do we know this number? How do these people get, are they paying into the system? Well, largely through, they obtain falsified Social Security numbers. And so when the government tries to correlate at the end of the year a Social Security number to a name, and they can't do that, those funds are sequestered. They basically go into a suspension file at Social Security and at CMS, and that's where we get these numbers in terms of how much money we think is contributed to taxes, Medicare, by undocumented immigrants. It's by looking at those undocumented or unverified Social Security numbers at the end of the year. Now, what about access to health care? Well, probably the most recent data is that undocumented immigrants, about 45% of the population, has limited or some access to some health care insurance. That is through a bunch of different services, and it depends again upon the state. It may be some employer-sponsored insurance policies. It may be from CHIP, the Child Health Assessment Program, and some of it may be through falsified documentation as well. Now, other ways are through a spouse that may be employed and who is documented and is giving insurance to their undocumented spouse. Can also purchase private insurance on the health exchanges. There may not be any public assistance, but remember, one of the stipulations of the ACA, which really makes a big difference, is that pre-existing conditions were no longer an exclusion to get insurance. So if you were a patient with chronic kidney disease or end-stage kidney disease, you now could pay for your insurance on the exchange in the public marketplace, and outside of the assisted marketplace, you could now get insurance. And in many places, this was also supported by charitable donations to patients to support the access to get insurance through the ACA now that the restriction on a pre-existing condition was lifted. Now, some undocumented immigrants may be covered by student health programs, and then there's several states that use state-only funds to cover income-eligible children regardless of their immigration status. In June 2019, California also approved an expansion in coverage for income-eligible young undocumented immigrants up to age 25 as well. Now, again, this is about the issue in exchanges and dialysis. The Dialysis Patient Citizens Fund urged that dialysis would be considered an essential health benefit in these programs and that there would be no annual or lifetime limit to cover dialysis. Now, undocumented immigrants cannot buy plans in the exchange, at least in the public part, but they can buy private insurance. And again, that may be supported by charitable donations or other sources that allow undocumented immigrants to get access. We have no idea what that number is, but clearly we know in some states, especially in Texas, that that occurs quite regularly and has been a source to get access to insurance to cover dialysis in some cases. Now, what are the consequences of no insurance coverage? This, I think, is probably obvious to most people in the room, but you're going to have delayed and sporadic medical care. You're going to have fewer diagnostic and therapeutic medical services. Patients are going to present with more severe illnesses, if they present at all. They're going to have longer hospital stays because they're iller. They may not have easy discharge pathways to get them home. They may not be able to get home health services. They have poor health outcomes, higher mortality, and they have a high cost of delivering services. And it really leads to ethical dilemmas as well, as I'll come back and show you, especially for providers who are providing these sources, care, yet are really stymied in doing what they think is best sometimes. Now, what do we know about estimates of the undocumented immigrants for ESRD? This is a paper by Rodriguez. We've also published data on this. And basically, it's an estimate that looks at prevalence of different populations in different states. It looks at ages and tries to make an estimate based upon that of what we think the ESRD population may be. You can see that the range is quite wide. It's anywhere from 5 upwards to 9,000 ESRD patients in the United States are undocumented. Again, that's an estimate. We think that that's probably relatively close, but again, it has a wide range of where that number may be, and we don't have good data on this. Now, what's the impact of no insurance on ESRD care? We now have very nice studies that have documented this that I'll go over, but in summary, there's no or inadequate pre-ESRD care, ESRD care. Patients present with the need for dialysis. I would argue probably in this room, if there's fellows here, the patients that you've seen come in with the highest BUN and creatinine levels, the patients that are the most uremic tend to be those undocumented immigrants that have had no prior care and are presenting really on death's doorsteps because they're critically ill and can't wait any longer before they get their care. There's more dialysis initiation as an inpatient with higher associated costs. They're certainly less likely, almost rarely, to start dialysis with an AV fistula or to even get an AV fistula. Patients present with more severe illness. They're more likely to rely on emergency or hospital-based ESRD care, and they have inadequate support services such as a nutritionist, social workers, and access to medications to treat ESRD complications as well. Now, let's talk a little bit about coverage and sort of the history of coverage of undocumented immigrants. This, I think, is a fascinating area, and the legal issues here, I think, are really pretty interesting when you think about them. Now, remember that nearly all U.S. citizens and 5-year permanent residents are eligible for standard hemodialysis as a result of the 1972 amendments to the Social Security Act. Undocumented immigrants are excluded from the federally funded insurance programs such as Medicare, Medicaid, as well as the exchanges, the Patient Protection and Affordability Act. Now, some states have gotten around this by using state funding to fund chronic dialysis care for undocumented immigrants, mostly through emergency-only programs. Now, the origin of this emergency-only dialysis began with the 1986 Emergency Medicine Treatment Act, the EMTALA Act, which allows the use of federal Medicaid funds that come to the states for medical services provided to undocumented immigrants, and I'm going to come back to this, if such care and services are necessary for the treatment of an emergency medical condition. Therefore, in many states, the interpretation results in many patients not receiving dialysis until they develop the most severe complications of advanced kidney disease, uremia, volume changes, hyperkalemia, metabolic acidosis, mental status changes. You have to be incredibly sick to be defined under the term emergency. Now, these are sort of the relevant laws and statutes that apply, which I just discussed. But EMTALA really is the key. And again, this act in 1986 required that hospitals assess and they treat emergent conditions. And it does include the care of undocumented immigrants during an emergency episode. The services are paid for in part by the Medicare Prescription Drug Improvement Act, the MMA. It accounts for about $250 million a year in federal funds. That does not fully pay for the program at the state level, so states usually have to use their own funding mechanisms as well to support this. The $250 million falls well short of the cost of providing EMTALA care, and these funds are restricted to use in emergency departments only. Now, emergency Medicaid is the other source of funding for chronic dialysis for undocumented immigrants. And it's a category of Medicaid spending that's available for life-threatening emergencies. Now, the definition of emergency, again, is really what varies across states. A few states, that include dialysis within this category on an ongoing chronic basis, and I'm going to come back to this because this number has actually grown to include states like Colorado, include North Carolina, Virginia, California, New York, and again, Colorado, who recently added maintenance dialysis. Now, the state policies and laws, again, come down to the different rules and regulations of what constitutes an emergency and how a state decides to use their emergency Medicaid funds. And because of that, there's been several state-specific lawsuits that have really tested the definition of what an emergency is. Now, this is the definition on the statute of what an emergency medical condition is. This comes right from the Federal Register. Basically, it's a medical condition, including emergency labor and delivery, manifesting itself by acute symptoms of sufficient severity, including severe pain, such that the absence of medical attention could reasonably be expected to result in health in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of any body part or organ. And state Medicaid plans have to conform as well to these statutes. But there's a lot of variability between the states. There's states, again, that cover it. There's states that clearly say they will not cover it, such as Texas and New Mexico, and Georgia in 2006 removed it from their state Medicaid funding. Now, the case law that governs what's defined as an emergency medical condition that's applied to ESRD are from two cases. The first is what's known as Greenery Rehabilitation versus Hammond. This case involved 3 illegal immigrants from Mexico who had suffered a very severe traumatic brain injury. And because of that, they were left needing chronic care. As part of that chronic care, they needed parenteral nutrition. They could not feed themselves. And Greenery, the rehab center, had tried to get that paid for by government funds, but they were denied coverage. According to Greenery, they said that the ongoing use of that total parenteral nutrition was really part of the extended emergency period of the patient's care. Without that, the patient would suffer and they become life-threatening. However, the initial ruling, which supported the rehab facility, was subsequently overturned in the Court of Appeals. The second case that's used in the ESRD world is this case, which is a case in Connecticut. Actually, this is the court ruling in Greenery, I'm sorry. And this language is important and really has been used by lawyers in states to deny dialysis, is that emergency conditions are determined as those in the absence of immediate medical attention that could reasonably be expected to result in placing the patient's health in serious jeopardy. It excluded long-term care. This ruling, again, has been broadly applied to denied ESRD care and as a maintenance in many, many states. The second case, this one is a Connecticut Department of Social Service case, basically that said, quote, hemodialysis did not constitute an emergency medical condition. They used Greenery as their definition, and they found that the continued and regimented care of dialysis did not constitute emergent care, despite the potential fatal consequence of discontinuation of care. So those are the two cases that you'll see cited by state legislatures when they tried to deny ongoing emergency Medicaid funding of dialysis for undocumented immigrants. So what are the costs of providing care? The costs are very difficult to basically determine. This is probably the most recent study. And if you looked at probably covering the entire spectrum of undocumented immigration care and realistically looked at the number of people that would enroll in plans and use them, the costs are probably about $10.5 billion. So it's very expensive to cover patients, but there's a cost in not doing it as well. And I think ESRD care shows that, as I'll show you. So let's talk about the effects of no insurance cover on ESRD care and outcomes. So this is an excellent study looking at scheduled versus emergency-only dialysis. It's an observational cohort study of 181 eligible adults with ESRD who are getting emergency-only dialysis in Texas, and they became now eligible and applied for private commercial health insurance using the exchange modality, and that was done in February 2015. 105 of those patients received coverage with not-for-profit support, and they were enrolled in a scheduled dialysis program. 76 were not enrolled for non-clinical reasons, and what they showed is that there was a much higher mortality in emergency-only dialysis, 17% versus 3% in the patients that did get insurance. There were fewer admissions and hospital days if you had scheduled dialysis. And importantly, there were higher costs, about $4,300 per patient per month with emergency-only dialysis. And a nice quote that they have from this paper is that the absence of coverage led to a higher death rate and, in fact, at a higher cost. Another study by Dr. Cervantes, who's really one of the leaders in this field, has really shown also that emergency only versus standard dialysis in undocumented immigrants, some of the costs and consequences. This is a retrospective cohort study that looked at undocumented immigrants with incident end-stage kidney disease. They initiated emergency hemodialysis in several places, in Texas and Colorado, or standard dialysis at UCSF between a period of 7 years, between 2007 and 2014. There were 211 patients in this study. 42 were in the standard dialysis group and 169 in the emergency only. And the outcome measure here was mortality. And what you found, just to get to the end of the study, and really the take-home message, and again, not surprising, I think, for all of us, is that the mean 3-year relative risk of mortality, the hazard rate of mortality, if you got emergency-only dialysis, was nearly 5-fold higher. If you looked out 5 years, what you found is that the mortality was more than 14-fold higher. Really dramatic results in showing that emergency-only dialysis really is giving you very suboptimal outcomes. This is just the graph showing you the Kaplan-Meier curves, showing you in the bottom standard hemodialysis versus the cumulative mortality with emergency dialysis at both 3- and 5-year intervals. Now, other studies have also shown that emergency dialysis is associated with a 10-fold greater increase in inpatient hospital acute care days, 3-fold less ambulatory clinic fair visits, and there was no evidence in difference in bacteremia episodes. Other studies, emergency-only HD, 4 times more costly than standard approaches. That represented about, actually, emergency ESRD users also are what's called super users. They use a lot of healthcare through the emergency room. But even when you take that into account, the cost of that small super user group actually exceeds the rest of the super users combined. And more than 90% of the patients receiving emergency-only hemodialysis were employed prior to initiating, but when they start dialysis, that employment number goes from 90% down to 14%. Now, the illness experience, too, I think this is very profound and very sad when you think about this. You can imagine if you're an ESRD patient who can get only emergency-only dialysis when you're on death's doorstep. How anxiety-provoking that is for both you and your family, that you know you have to wait until you are critically ill, between you are short of breath and you can't breathe, or you're feeling so poorly that that's the only time in certain places that you're going to get the care that you need. That's incredibly anxiety-producing. It leads to really significant consequences for families. People can no longer work, and it really changes the whole dynamic for those families in very detrimental ways. Despite that, when you ask the patients, they are incredibly grateful to their caregivers in the system providing whatever care they can have access to. If you look at clinicians' perspective, the people who care for these patients, what you also find is that there's a huge amount of emotional exhaustion coming from witnessing these episodes of care. Clinicians become more detached. There's more burnout. They feel like they have lack of control. They become exhausted. There's lots of moral distress. And really, the other thing that occurs is that oftentimes on the beneficial side, there is a strengthened sense of altruism on these caregivers' side. Finally, a couple other things just to mention. When you look at illegal immigrants comparing their maintenance hemodialysis versus emergent groups need more transfusions, more emergency room visits, more ICU days, more hospitalizations. Again, something that I don't think is surprising to any of us. So the last study I want to show is that what you see also is that the initiation of dialysis, not surprisingly, is suboptimal. This is a study out of New York State where basically patients required admission to start dialysis. A small number, only a quarter, had any pre-ESRD care at all. Patients with undocumented started dialysis at very low GFRs, most of them GFRs less than 5. And when they did, they had very low hemoglobins, and they almost always started dialysis with catheters. In terms of peritoneal dialysis, there's lots of barriers, unfortunately, in using peritoneal dialysis in the undocumented population. Place to store supplies, stable home environment, the willingness to give a home address sometimes is a big issue. The need to be able to accept and be present to accept home deliveries is actually a huge barrier. There's one center that I know of in Houston that operated in 2017, and they've had limited experience, but they've struggled with using this modality. But certainly may be a viable option, something to think about for select patients. Lastly, what about transplant? Probably there's fewer than 400 undocumented immigrants that receive transplants over the last 20 years or so. Most of those are in California, and most of those are from living donors. In 2014, Illinois actually became the first state to pass legislation that allowed undocumented immigrants to be listed for transplantation. This actually received significant opposition, and several years later, the program was defunded and removed from the legislation in Illinois. In that state, while the program was active, about 50 patients did receive a transplant that were supported by usually faith-based charities in Illinois. Again, very limited experience in data, and again, there's sporadic cases that occur locally, mostly through charitable donations. Now, RPA in 1999 had a statement that came out sort of what, as clinicians, we should think about in this population. And basically, they said is that healthcare professionals and healthcare systems have an ethical obligation to take on this problem. They believe that the federal government also had an ethical responsibility to provide care within patients in the U.S. borders. They believe that the financial burden should not fall on those states with the highest number of uninsured citizens, but should be a national responsibility. They also said that due to the unique nature of ESRD, all citizens and non-citizens with ESRD should be eligible for emergency federal funding if they do not have insurance or resources to pay for the care. They also said nephrologists should not be expected to act as agents for the Immigration and Naturalization Service. It's not our place to report patients, and should not be expected to report them and should retain confidentiality. So I think this leads to a couple of ethical and political questions that I'll leave you with, and maybe we can discuss at the end. Should we deny chronic dialysis to support patients, and is emergency-only treatment at all a rational approach? And how do we justify that? Should we provide dialysis support without optimizing a patient's access situation? Is what we're doing, if we're going to provide that care, also a reasonable thing to do? Should we provide dialysis support without addressing other ESRD-related conditions that clearly impact on patients' outcomes? What about the costs of trade-offs of providing emergency-only care versus ongoing care versus ESRD patients? In states like California, the clear discussion point was that they recognized that emergency-only care was going to be more expensive for the state, and they made an informed decision that they were going to provide chronic care. In my state of Virginia, our state legislature was actually fairly forward-thinking and also thought the same after they did an economic analysis that looked at the pros and cons. Unfortunately, the economics for states sometimes outweighs, not surprisingly, sometimes the value-based and the ethics involved here. But in certain states, the cost structure really supports maybe chronic dialysis is the more beneficial way in terms of a cost-based analysis. Can we reasonably jeopardize our ability to provide care for uninsured patients by providing de facto free care to uninsured illegal immigrants? This is an argument that comes up many times. We have only so many dollars to spend. How are we going to spend those dollars? What are the trade-offs? What are the responsibilities of caregivers versus policymakers versus administrators? And how do we resolve those tensions when we have people with various different perspectives who are different stakeholders who have to make these decisions? And lastly, should the burden of ESKD care for undocumented immigrants be spread to all dialysis providers, for-profit and not-for-profit? Do we all have a responsibility? Or does that responsibility really rest in the state or more publicly funded venues? These are some of the questions, not all of them, that I think we face with this difficult topic. So in summary, undocumented immigrants face really significant barriers to getting what I would, and I think everybody would say, is appropriate care. The mechanisms to provide this care are difficult to navigate. They're mostly local and state, and they have great variability, great variability. The consequences of ESRD in this patient population are now well documented in excellent studies that show that care is often suboptimal. The economic trade-offs may favor the provision of appropriate chronic care versus relying on emergency care. And the political, economic, and personal values are very strong influencers in this debate. And again, reasonable people can have very different opinions, but we need open debate and discussion and less variability in the care to, I think, provide better outcomes. So thank you very much, and I'll look forward to the discussion.